Make sure they can tell who you are in the personal statement. Don't add a bunch of facts. No, that's already going to be on your application. Tell us more about who you are, why you decided to be a PA. Hi, everyone. Welcome to eShadowing. Hello. So today, hi, I'm Rodeline, as you all may know. Today, I am actually on a computer, so that's probably why the it's clear and you probably hear me better, and it's just better overall. I'm on my computer rather than my my laptop, because I am home in Atlanta just for a week. Hi, everybody. Thank you. Thank you for the birthday wishes. Thank you. Yeah, my birthday was yesterday. I turned 30. Thank you. Hi, everybody. Hope you're having a good Monday so far. Thank you, guys. So, unfortunately, our guest, Gabriella, who was supposed to do the asthma, immunology, and allergy session, she had to cancel today. She kind of canceled a little last minute, so I was not able to get another guest for today. She canceled just like early this afternoon, so unfortunately, I was not able to get another guest, but I didn't want to just not have a session, because I love doing this. So, and you're still going to get credit as always. So rather than just cancel it, I wanted to still do something for you guys. Just kind of make it like a wild card night where I just do a Q&A, as I always do when I can't get a guest, or go through a case study, or if you want to hear about any interesting cases or whatever you want to know tonight regarding the PA specialty and what I do, then just let me know. Does Gabriella have an Instagram account? I don't know, because when they give us their information, they do provide social media, but I don't think she provided her social media. But her name is Gabriella Romero, and she is in asthma, immunology, and allergy. So she was going to discuss asthma and all of that, and allergies, especially it being into spring now. So I'm sure a lot of us have allergies. Would love to do case studies. Sure. Or, even if I didn't actually create a PowerPoint for a case study, but I can just kind of go off the top of my head or discuss some interesting cases that I've had in the past. So let me see if anybody has any questions to start off with. We can do like half questions and then half case studies. Sorry if my eyes look red. I have allergies. Like every time I get back into Atlanta after being gone for a while, I just start sneezing, itchy eyes, just my nose is stuffy. So a little introduction for us newcomers. Yes. So I am Rodeline. I hosted eShadowing. I hosted the pre-PA eShadowing. Dr. Gray does pre-med eShadowing. So I am a PA. I've been a PA for 4 years now, a little over 4 years, going on 5 actually. Since 2016, I'm in the ER where I've done most of my PA training or career. I've been in the ER for over 3 years, going on like 3.5 years. And I love mentorship. I also have a startup that I started that's focused around community building in the medical field and connecting others in the medical field. So not just PAs, but all students and pre-professionals, professionals, just in healthcare. It's called MedSembly. And yes, that's a little bit about myself. And I'll put my social media handles. I'm really just on Instagram because I'm trying to be good with social media, but I can't keep up with all of them. So Twitter, I can't keep up with. Facebook, I try to, but can't really keep up with. I'm not on any other social media. Okay. Some of the questions are repeated questions, or I've answered multiple times. I probably won't answer and just kind of refer you to my Instagram, where I have some Q&A videos or past eShadowing videos. Some of them do end up on YouTube, so you can also check out YouTube. How are the hours working for a physician? You don't necessarily work for a physician, at least not in the, you do work for a physician if it's a private practice, but or even if it's a group, like a hospital group or a medical group, you don't necessarily work for the physician, especially the ER. As I said, you either work for the hospital, you can work for a recruitment firm. I work for a recruitment firm. I don't even work for the hospital. We can get into, maybe we can discuss a little bit about recruiters, just so you guys know about it to prepare yourself for PA school. But a lot of ways to get a job when you get into your career is via recruiters. And a lot of you guys don't know that when you graduate, which I feel like is so important to know. So I recommend getting in touch with recruiters. Your like last semester of PA school, get in touch with recruiters, either on LinkedIn. They'll start sending you emails. You can go on the AAPA website or any pre-PA website. There's like a bunch of like resources where you can get in touch with recruiters and recruitment firms. I have a lot of information on those on my app, but yeah, the recruiters are the gateway to a lot of these jobs, okay? They can get you in, they can help you with your application or your resume, or give you some pointers on how to, get that job. They're the ones that kind of facilitate the whole hiring process. They're the middleman between the hospital or that group or that job office, whatever it is, and you. So get in touch with recruiters. So yeah, I do not work for a physician. I work for a recruitment firm. And that's basically how it's kind of always been. My first year, I worked for a physician. My second, third, fourth years, I've worked in the ER. So I've just been working for a recruitment firm that staffs the ER. So, or staffing agency, as people also call them. All right. Yes, CASPA accepts virtual shadowing, but it's really up to the school. Experiences at my job. I'm sorry, I see a lot of different questions, and being that I have to like also do this and go through the chat, yeah. Can you discuss tips for reapplicants? Okay, reapplicants. I always kind of say to get in touch with the school to see, what you can do to, kind of make it better, or what advice they can give you, or kind of going through what you think is your weak spot. If it's your GPA, work on your GPA. If it could have been your essay, work on your essay. If you got through to an interview and then you didn't get in, then I think it's really your interview skills. Work on your interview skills. If you made it to the interview and you were waitlisted, work on your interview skills, because that means that they liked you enough to bring you on to get to know you. But then you go interview and then it's like, oh, what's going on? You're not really either who you say you were, or like what was on the essay, or your application doesn't match, or, just work. It could have been that you were just nervous that day, which is okay. But whatever it may have been, or whatever your weak spot could have been, work on it. Like I said, try to get in contact with the school to see maybe if they can give you any advice. A lot of times it is hard to, do that with schools. You can also discuss it with PAs that are in the field, and they can give you advice. Like myself, I'm always, open to emails and advice. So if you want to send me your stats, send me your essay, send me whatever you want to go over, I can kind of give you some advice on, what may help you. It's free. I don't care. So, but there are like paid services. They're probably going to be a lot more quicker and more professional than me. But yeah, so that's what I can say for reapplicants. Will colleges look down? As far as eShadowing, a lot of people ask this, and I see that's a recurrent question. eShadowing. I do not know if all schools accept eShadowing, if they're okay with this. A lot of times schools have reached out to me to verify that the students actually did participate in the eShadowing. And I would say, yeah, they did, and they're fine with that. A lot of schools are A-okay with it because of COVID, because it's harder to find in-person shadowing. So I don't think anything is wrong with it. I actually think it's fine. It's helpful. You're actually consistently talking to a PA or have access to a PA. So eShadowing is really based on the school's preference. You can put that down on CASPA or in your application, but at the end of the day, if a school wants more information on who did it, wants to watch videos, wants the information from that PA or coordinator directly, just tell them to reach out to me or give them my contact information. And I'll put that in the comments. Okay. What do we put as organization on CASPA? It's called Medical School Headquarters, the organization. What made you choose ER as your specialty? I love the ER because I love learning. I love, like I said, learning new things. It's all the things that you see in the ER. It's a specialty where you know a little bit about everything, but you don't know the specifics. You don't it's just you know what you know, and you know like how to diagnose a lot of things. But as far as like you know the in debt on stuff, we're not gonna know that. Okay, I forgot the phrase they use for it, but to describe ER professionals. But yeah, and we're quick, we're on our feet. I'm kind of a busybody, so I like that. I like for the time to go by fast. I like having things to do, seeing new things every day. I don't like just working in one specialty where I see just one thing all the time. Like I thought I liked OBGYN, but I can't see mother and baby every single time or get used to it. So I like seeing a little bit of cardiology, a little bit of OBGYN, a little bit of pulmonary, just see a little bit of everything at once. High schoolers. If you're in high school, it's basically, you can do this to, start learning about the paid profession. Of course, it's not going to be any type of eShadowing credit to submit to a school, but just to, dabble and get to know what PA school is like or the PA profession is like. I'm sorry, I'm trying to be organized and go through this, but by the surgical, okay, somebody said advice for students who are interested in primary care but are intimidated by the surgical components of PA school rotations. Let me tell you guys, I don't like surgery at all either, but it is very easy. It's nothing intimidating. I am very clumsy, so I'm like, I'm not gonna make it in the OR. But it's like you just you help, you kind of like first assist the doctor. But I mean, I had a really good surgery rotation, so I'm not even gonna say that it's really easy because some surgeons are really mean. My surgeon was not. So he let me first assist and do certain things, and he didn't pimp me. Pimp means to intimidate you, ask you all these questions that you may or may not know, and it kind of sums up to being embarrassed. He didn't do that. A lot of doctors, preceptors will pimp you throughout rotations just to kind of see how much you know, or to just, like I said, intimidate you. But I didn't really have that throughout my rotations. I had some good preceptors. But yeah, surgery, it's nothing to be embarrassed or, feel like you don't know anything. You'll learn. And like I said, you'll first assist. If you're lucky enough, there'll be a PA in the practice, and you'll a lot of times deal with the PA. And it's going to be a lot of suturing. You can practice your suturing, closing wounds, and don't be afraid. It's really, rotations rotations were 6 weeks for us. So it's really just 6 weeks of, whatever it is. If you don't like a specialty, it's just, think of it. It's just 6 weeks and you're in, you're out, you move on to the next. So. The role of a PA in primary care is very similar to the role of a physician in primary care. So you'll see just about all ages. You'll see sick and well patients. So you really get good at doing physicals. You'll be doing physicals, and don't just be doing physicals like they do at the doctor's office, where they just go in, listen to your heart and lungs, ask you these questions, and then leave. Actually, really practice a physical. Do a ENT exam, do a heart and lung exam, do musculoskeletal, do neuro. All those things that they teach you in PA school when you get started in primary care, do them. That's really what primary care is, kind of looking at the body as a whole, and then doing physicals. When you do the physicals, whatever you do the physical, if you find something abnormal, you can either diagnose it or do some blood work to, help reel in a diagnosis. And then from there, you can either refer the patient to a specialist or treat it yourself, or kind of, do more tests to see what's going on. But that's really what primary care is. And then a sick visit is really oh, I got a cold. If it's a sick visit to where they're really sick, you just send them to the ER. So that's, I never actually did a primary care rotation because I love ER and urgent care so much. I did 2 ER rotations and 1 urgent care. My urgent care counted as primary care. So you'll see a lot of primary care stuff at urgent cares because a lot of urgent cares do physicals. They do sports physicals, which is you'll also see in primary care. Some of them also do like DOT physicals. DOT is Department of Transportation. So like truck drivers, police officers, people that are in commercial transportation, they need, especially truck drivers. I think police officers may have their own thing, but anyway, truck drivers, they'll come in and need a physical, a DOT physical, and they need to meet certain standards to keep, doing their job. So you'll do that a lot in urgent care. You'll see a lot of injuries. Maybe not a whole lot in primary care because primary care, you got to set an appointment. And if it's bad enough, they always just tell you to go to the ER. So, yeah. Do I know anything about traveling PAs? I'm actually a traveling PA right now. I'm in New York. Well, right now I'm not in New York. I'm taking a break. I'm going back to New York for another 3 months this Friday or Saturday. And then I'm coming, I officially will be back in Atlanta July. I'll be living my best life. Okay? Did you do pathology? Pathology is not a rotation. Yes, surgery is mandatory for PA school, as far as I know. No, PAs, as far as where you are in the emergency room, it's really dependent on that hospital and it's dependent on that hospital and how they kind of I wouldn't even say their level of respect for mid-levels or APPs, but what they want their advanced practice providers to do. Or it may not even be that hospital, but the agreement the hospital and the recruitment firm comes with if they choose to have recruiters. Like some hospitals just have PAs in fast track, which I think sucks, which I think is terrible because you're just seeing level 4s and 5s. You're not seeing actual sick patients and getting that real experience. So if a hospital tells you that, you're just going to be in fast track, I would probably do it like my first year or something, or not even, maybe not even your first year. I would probably do it once you get some experience and you kind of just want to chill and then like go to a hospital like that. But I recommend you guys go to hospitals where you can fully practice the way that, you should be, how you got your degree. If you want to be in the ER, go to a hospital that allows you to see level 2s, 3, 4s, 5s, whatever you want. Not just sit in fast track or not. Some hospitals, all they let PAs do is screen patients. Screening is basically a patient walks through the ER, you look at them, you make sure that, they're not dying or don't need any rapid care, and then you kind of order tests for them, and then they go sit back in the waiting room. No, that's not no. You can do that a few days or so out the month, but no, don't let a hospital just have you sit there screening patients. You want to actually practice what you learn. So definitely, if it's a hospital that hires recruiters, make sure you ask them about like the level of work that PAs do or the scope. I mean, I wouldn't even call it the scope because you should be able to practice to your full scope. Sorry, I'm just kind of reading comments as they come. What are the pros and cons of being a PA to an MD? If you're on that PA, I don't know if I want to be a PA or I don't know if I want to be an MD. Okay, for PA, for me, I chose it because I didn't have to go to school the next 40 years, okay? I was like, okay, I do this, I'm done, I start my life. I just need to knock this out in 2 years rather than another 8 years. So I finished PA school at 24. Yeah, I think I was 24 as compared to possibly finishing PA school at 30, which I am now. So no, I started PA school at 20. Yeah, I don't know. I finished PA school in my mid 20s, whatever age I was in 2016. So wait, I've been a PA for 5 years. No, I haven't. I've almost been a PA for 5 years. Okay. Talking to myself. Okay. So I don't even remember the question anymore. Oh, PA versus MD. Okay. So, yeah, I like PA because this, school was very short. I didn't have to do all that extra time. And, if finances mean a lot to you, or debt, you're not going to have so much debt coming out of school. I mean, of course, you're going to make way less than a doctor. But you just don't have to worry about like paying off debt. Or coming out of school with so much debt, if that matters to you. And then if time is really important to you, or kind of getting your life started at a certain time, I always think that, you have all the time in the world. But if have that type of personality where, you have a family, you have this, you have that, you have this to do, you want to do this by a certain age, you want to do that by a certain age, even though things don't always happen as planned. But if you're big on time and you don't want to waste time, but you want to be in the medical field and start seeing patients, then PA is for you. Because like I said, it's, 2 years versus 6+ years. Because medical school is 4 years. And then you have to do residency, which can be like 3+ years. Or 2+ years, but depending, and then if you want to, do a residency and be a surgeon or be a cardiologist or whatever, you're looking at like 10 years. So, I mean, that was like the breaking point as far as like, or deciding factor, as far as PA versus MD. And, they say MDs have more liability than PAs. But I mean, if you get sued, you get sued. Everybody gonna go down. So, so liability is very different, of course. A lot of things may fall back on the doctor, but like I said, that's still gonna be your license at the end of the day. So don't think that, just because I have a supervising physician on my note that he's responsible. You're still going to be responsible. And if you have a conscience and yeah. So yeah, that's maybe a deciding factor for some people, the level of liability. And then, of course, I would say a con, I guess, with being a PA. I mean, you're not going to know everything. You're definitely not going to know as much as the physician. So if you're the type where you want to know everything there is, even as a doctor, you're not going to know everything. That's why there's specialists. That's why people specialize in different areas. So you may be in the ER and you need a consult with the nephrologist because you don't understand, a patient's CT report or whatever it may be. So you're never going to know everything, but you'll definitely know, as a physician, you'll definitely know a lot more than the PA. But okay, somebody asked about classifying the different levels of experiences on CASPA. I definitely need to do more research on that because it was completely different when I applied. I've been a PA, as I said, going on 5 years. So I applied for PA school in 2013, which was 8 years ago? Okay, I had to count that in my head. But I applied for PA school in 2013, which was 8 years ago. So CASPA has changed greatly since then. But for me, it was your patient care experience and healthcare experience was the same thing. So I had shadowing hours, I had volunteer hours, and I had my healthcare experience or hands-on patient care experience. But I'm hearing that healthcare experience and patient care experience is different. I don't know how, because hands-on experience is hands-on. But yeah, so it was like three ways to get experience. So or really two, because I just did shadowing and my healthcare hours. My healthcare hours was as an LPN at a nursing home in Gainesville. So what's the difference between patient care and healthcare? That's what I'm not understanding, I guess. They're asking for a lot. I feel bad for them. No, I do not know any PAs that practice outside of the U.S. Listen, is there an option to be an internal medicine PA? Yes. As a PA, you can specialize in just about anything. If they're hiring, if you go on Indeed and they say need a PA for forensic medicine, you can be a PA in forensics, okay? You do not need any extra training or formal training. You may need, of course, on-the-job training or experience once you start working there. But if they say, I'm a PA in immunology, you can be a PA in immunology. You can be a PA in anything you want. You apply for the job, you get the job, you get some experience and training when you start, and then that's it. PA is not only in the US, PA is in a lot of countries. It's also in Canada. Okay, healthcare is hands off, so shadowing is considered healthcare experience. Why did you choose to go to PA school instead of NP? Did you not like the nursing model? No. Honestly speaking, nursing model, PA model, medical model, all of that, as far as PA and NP, I mean, yeah, it's all the same thing. When you work, you're gonna work with a nurse practitioner. A nurse practitioner can do a lot of the same things a PA does. I found that, or I'm learning that it varies by state and what's common in that state. Like my ER, nurse practitioners do not work in my ER. It's only just PAs. But I've learned that working in New York, a lot of nurse practitioners just kind of either do primary care or they're midwives. They don't work in other specialties like PAs. And it's kind of the same. Well, it's not really the same in Georgia. In Georgia, a nurse practitioner works in a lot of different specialties as well. And the same thing in Florida. Like there was a nurse practitioner in cardiology. There's nurse practitioners in the ER. There's nurse practitioners in that can also do surgery if they'd like, or psych. A lot of them also do psych. But I guess up north or the East Coast, it's based on, and maybe based on the amount of schools in that area for nurse practitioners. So there's be more midwifery schools, or psych NP schools, or also what that hospital or practice may allow. A lot of hospitals and practices, they say PAs only or NPs only. I'm not an OBGYN PA. I am an ER PA. We did have an OBGYN PA a few sessions ago. It may be on our YouTube. I did not do the NP route because it would have been extra school. I became an LPN in high school, so it was just like a thing that I just had. So it's not like I became an LPN to become a PA. I became an LPN because I so happened was an LPN when I decided to be a PA. So in order to be a nurse, I would have had to go back to school as a nurse because I was not pursuing a degree in nursing. I was pursuing a degree in sociology to become a PA. So I would have had to go to RN school, then work as an RN for a year or whatever, or maybe go straight to NP school, but it would just been more time. And I'm just big on time. An LPN, licensed practical nurse. You can search medical school headquarters on YouTube to see if that helps. PAC, anesthesiologist. Actually, I haven't heard of that for PAs because there's actually an anesthesiology assistant career, which sounds like a physician assistant. So they help and it's also kind of like CRNAs. So it's very similar. So I don't think PAs really do anesthesiology, only because it's very, very, very specialized and you can go to school to be an anesthesiology assistant. Do I think the PA profession is becoming oversaturated? No, because there's a lot of states that there's not many PAs in. It's really what you make of it. If there's too many PAs in one state, you can easily move to another state and get a job. And maybe not even another state. You can easily move to another region in your state, another county in your state, and they'll have a need for PAs. Patient care out. How to record. What do you mean how to record patient care hours? If you are having difficulty. Okay, let me tell you guys, because I get asked this question a lot too, about how I was able to find a PA or MD to shadow in person. What I did was, this was back in 2012 or 2013. So we still had this thing called the white pages and the yellow pages. So what I did was I went through the white pages. I literally spent a day going through the white pages and calling every single office in my area until somebody said, yes, we will accept you. We will take you. That's what I had to do. I spent a whole day calling doctors' offices. And I don't know, I probably called about 20 and somebody finally said yes. So if you have to go on LinkedIn, search through LinkedIn doctor's offices in your area, even go through the job page and like look at jobs that are hiring and ask, oh, I don't know. I just said jobs that are like the jobs pages because it'll probably be easy to filter and find jobs practices in your area. So you can even go on LinkedIn, find doctors in your area or PAs in your area, message them. You know, at least on LinkedIn, they see your profile. They kind of have an idea of who you are, what your goals are, so go rather than like a random email. So even if you go, or calling the place, go on LinkedIn, explain to them that, you would really love to shadow in person. The coronavirus has made it very difficult. You have been doing eShadowing and really understand the PA profession. And you're very, interested and eager to become a PA and would love to, see how a day in the life is, see in person how a day in the life is and how they interact with patients. That's easy as that. Send a 2-3 sentence introduction, message them on LinkedIn. But yeah, so, now they got LinkedIn, they got Facebook, they got all these ways. I say LinkedIn because it's a professional environment and setting, so they'll probably be more receptive to it rather than like hitting them up on Instagram or Facebook or even email. Yes, I shadowed at an ENT clinic. There were 3 PAs there. I had like a main PA that I shadowed with, but he would let me, go with whoever like was available or whoever had patients to see that day. So, and the doctor was pretty nice. I did talk about accreditation in the past. I do not recommend applying to a school that's on probation. I recommend applying to a school that has continuing accreditation and maybe provisional. I don't know what developing, what's the difference between developing? I didn't know developing was a new one. I thought it was just continuing probation and provisional. But provisional are for new schools. If it's a really good new school, really good popular new school, then yeah, like if UF was to open a PA school in their provisional accreditation, yeah, apply there. UF is, a really good, well-known school. So you already know that they're going to get continuing accreditation. But if it's some random school, then you probably want to wait till they get actually fully accredited. My Instagram at Rodeline Joseph. My first last name _ and MedSembly. Okay, we're gonna start some case studies or a case study in like 2 minutes. How many hours of shadowing? Listen, when I was doing things, like I said, it was not as crazy as it is for you guys now. I only had 60 hours, and I got in with 60 hours of shadowing. I did it for 6 weeks and I got 60 hours. But y'all, I see people have like 600 hours, 300 hours of shadowing, 150 hours. I'm like, dang, like, okay, you had a whole job. But I think if you have maybe a solid 100 hours of shadowing, but it also can be if you don't have a lot of hands-on experience, but you have a lot of shadowing, that can help. So, but if you have a lot of hands-on experience and a little bit of shadowing, that's also fine. So just have a good balance. How did you keep track of your shadowing hours? I either printed out a calendar and wrote how many hours I did that day, or I just kept track of it in a notebook. If you do not, as far as gap years, if you do not have a lot of hands-on experience, do the gap year. Take a gap year and get that experience. Work full-time. Work as much as you can to get that experience. Volunteer hours, I don't remember how many I had. I didn't have that much. What really helped me was that I was an LPN before and I had all these hours already. So I didn't have to, I'm not going to say I didn't have to do much to get in PA school. I definitely did. But it just worked out for me because I had like everything already there. So that's why whenever I talk about my story, it's like, I was so lost. I didn't know where my life was headed. And then, I found PA. ooh, okay, I got this. Oh my gosh, it worked out. So that's great, Hannah. Okay, for patient care hours, CNA, paramedic, PCA or PCT, patient care aide or patient care tech, EKG tech, anything that'll have you touching a patient. I know there's people that do COVID swabs now or COVID volunteers, that LPN, of course, but LPN, it may take longer. It may take like a year of school. And you may not be able to get that done while in school full time. So that may be more difficult. But yeah, I mentioned a few. Yes, the recommendation from preceptors, it can be the year you apply, but just let them know that, oh, you can just hit them up. Oh, I need a letter of recommendation. Do you remember me? A good set of patient care hours is at least 1,000. Yeah, I said CNA was the first one I said. What helps you decide? For me, location was big. So it's like I said, it's really what's important to you. I've answered this question in the past, but I don't mind answering again. It's really what's important to you as far as what school you apply to. If you want to go to the top PA school in the nation and you want to be a stellar, going to the top PA school in the nation won't really change the type of PA that you become, because a lot of what you learn will be from working, like what you learn hands-on. As you gain experience when you start working. So, I mean, if you want to go to Harvard for PA school, sure, you can go, but that won't make you any different from somebody that went to a local PA program, like that went to a community college for PA school. So, so what's important to me was location, making sure I was close to home or that I was in a school in Florida. I really wanted to go to a public PA school, but there were not many at all in Florida. As a matter of fact, UF was the only public PA school because it's cheaper. Location and money is big to me. So I just ended up going to Nova. I applied to most of the Nova programs. I said I just ended up going. I applied to just about all the Nova, or 2 out of 4 of the Nova campuses in Florida, and I got in. But location, whether it's, another important one that I actually did not look up, but I recommend all of you, if there's one thing that you do, look this up. Make sure that the school, check their pants rate. Make sure their pants rates are at least 95%. I mean, if anything, at least 90%. Because you want to make sure that the students are actually passing their boards. That tells you a lot about the school and how they teach their students, okay? So make sure their pants pass rates are at least 90 to 95%. And if it's not on their website or clearly stated on their website, then ask them during the interview, what are their pants pass rates? Of course, make sure that they have continuing accreditation. And I didn't even know all this or look it up. So I'm just like, dang, good thing Nova's a well-known school, because who knows, like if I went to school with an 85% pants pass rate, I probably wouldn't have passed the pants. So yeah. Okay, so in 2 minutes, we're going to move on to case studies. Chiropractor assistant, that's a good one for patient care hours. The personal statement. For the personal statement, get personal. Make sure you're telling a compelling story. Make sure they can tell who you are in the personal statement. Don't add a bunch of facts. Don't say, I had this, my GPA has been this, my thing has been this, I have this amount of hours. No, that's already going to be on your application. Tell us more about who you are, why you decided to be a PA. Did something crazy and compelling happen in your life to push you towards the medical field? It's okay. Be a little vulnerable. Tell us really, share a funny story. Build a sense of build some empathy, make it seem like that, like they're excited to meet you and, you know, get to know who you are. And for the most part, that's what I've been seeing in the essays that I've been reading. Like, you know, one student, her essay, she was talking about, you know, how she was an athlete, which is completely different. Like, she's an athlete, and she had an injury, and then her injury led her to, you know, learn more about, you know, medicine. And I'm like, okay, great. I remember you from this. I mean, I know her name, but I'm not going to tell you guys. But it was a great, you know, thing to add to the essay, because it's letting me know, okay, this girl's an athlete, and she's, you know, her injuries have led her to, you know, learn more about, you know, the medical field, and, you know, how, you know, or just, you know, her interactions with others in the medical field, since she's gone to doctors' offices so many times. But yeah, just really get personal, really share your struggles, how you made it through this, how you know, accomplished this despite that. So yeah, get personal. Don't share a bunch of like facts and numbers. That's boring. Okay. Yes, the only accreditation status that I don't know is developing, but provisional is for new programs. It's like a period where, you know, the school's new, they're, you know, under a radar, you know, making sure that they do everything they're supposed to do to get continuing accreditation or full accreditation. Continuing is when, you know, they come and they've met our requirements to keep practicing or keep being a PA school. And then probation is a school that's at risk of losing their accreditation. So the reason that I say that I wouldn't apply to a school that's on probation is because if they lose their accreditation and you were to apply, if the current class would still be able to sit for their boards, but the new class, I believe, would not be able to sit for their boards. So it's just that risk of not being able to sit for your board. So you work so hard and so long to get to PA school, get to where you are, and then you find out that, oh, you're just going to be a PA and not a PAC, and you need that C to work nationwide, really. So yeah. Alrighty. Yes, it's all about sitting for your pants. That's what matters. Alrighty, so as far as cases in the ER, I told you guys my meningitis story. I'm trying to think of interesting cases. I told you guys my meningitis story. I'm trying to think of another really interesting case. The meningitis story was very, very sad. Another interesting case was, let's see. Rude experiences. I told you guys some rude experiences. Especially a lot of my rude experiences were actually in PA school. Okay, one rude experience, it wasn't even rude, it was just like, I guess, kind of arrogance on her part. But I had a patient that she actually came in, I think, like with like lower abdominal pain. And I get judged a lot. Because of my stature. I'm not sure if you guys can tell in pictures or videos or whatever, but I'm only 5 feet tall. So I'm 5 feet tall and I look really young. So people think, I approach them and it's like defense mode, like, oh my gosh, you're not touching me, you're a child. So this lady, she looked at me and she asked me, the first thing was like, how old are you? You can't, kind of like, you can't touch me. I don't trust you taking care of me. You're so young. She asked me, did I just finish medical school? And I'm like, no, I'm a PA. And so she came in with lower abdominal pain. And what happened? I first did a CAT scan on her. Her pregnancy test, her labs, all that were fine. But I think I did a CAT scan on her. And it was weird. And then I ended up doing an ultrasound on her. And I think she had like a huge ovarian cyst or whatever. And then, I had a long discussion with her about ovarian cyst and really educated her on it and like whether an OBGYN would do surgery or just watch it and all that. Like I really did spend time doing patient teaching. And she was so happy at the end. She went from not trusting me to asking me if I had a private practice, like if I actually did primary care and can she be my patient? So, I'm sure a lot of you are young and going into this really young, especially knowing about the PA career so early on in your college careers. So you'll probably be graduating at 22, finished all your prereqs, got all your healthcare experience, and then starting PA school at 23. By the time you're done with PA school, you're going to be like 25, and you'll be a PA, and you'll still be very, very young. So you'll get judged a lot. So what I say is that, whenever they ask me this question, I either lie and tell them I'm like 40, or I just kind of let them think whatever they want to think, and don't let that, change the way that I practice. Of course, I actually end up teaching, like spend more time with patients, like teaching, just so they can see that I know what I'm talking about. So it went from her really mistrusting me to her wanting me to actually be her primary care provider. So what are some experiences that made you emotional? My meningitis story really made me emotional. What other experience? Let's see. Okay. So another story. So I had this little girl. I had a child. PAs cannot own their own practice just by themselves. For every practice, you will need, like private practice or clinic, you will need a medical director. So it has to be a doctor. I'm just reading through the comments. Self-harm patients common in the ER like psych. Heck yeah, psych. Everybody's crazy. I'm sorry. That's the bad word to use, crazy. But psych is a major health, public health issue. Okay. No, I do not run codes. Okay, so let's discuss. Okay, so another story. I had this little girl. So she came in with her mom. And her mom was like, she's concerned that she broke her arm. Her mom's like, oh, she just got custody of her, and she's concerned that she broke her arm. The child was actually in the hospital. It was also like a social services issue. The child was actually hospitalized because she kept getting sick. She has all these illnesses, right? But I don't know. The child looked fine to me, but the mom said she had some illness. I forgot what it was. It's really dark here. Give me a second. It's the sun setting. Okay. It's kind of dark. This lighting's so bad. But anyway, the child, mom said that she was hospitalized for a long time, and they called child services for the mom while the child was at the children's hospital, so the mom couldn't see the child. So the child finally got released from the hospital and got released in the dad's custody. And then so mom was finally able to see the child, and mom's the one that brought the child to the ER, saying that she thinks that the child broke her arm under the hospital's care. So it did turn out that the child did break her arm. And so we had to do like a full scan, and then we had to transfer the child because it became a big social services issue, like abuse and all that. So the mom was like, oh, she's not sending her child back to that hospital. And then the mom tried to leave the hospital with the child. And we're like, no, you can't. You can't leave the hospital with the child because the child has a broken arm, and we're concerned that she may have, other, injuries. And the mom's like, either send her to this hospital or not. I'm going to take her and, I don't know. But it became a big thing. And we contacted the hospital, and they said that the mom is actually sick and the mom's not allowed to see the child. The mom has much housing. And so I think the police had to get involved and take the child away from the mom. But I was just like, I don't know. Like, I mean, the whole much housing thing is, that was my first time seeing it. Because, the child looked fine to me, but the mom kept saying the child was, sick and she broke her arm, but she really did have a broken arm. So it's like, who broke the child's arm? So that was something interesting. I don't want to get too much into it, but at first I didn't really think the mom had it. I was really concerned about the mom, being, saying that the hospital harmed her kid. and then the mom not wanting to go to any hospitals affiliated with that children's hospital, then that made me like kind of raise the side eye. But I don't know. But then if a hospital tells you, you know, gets child services involved, and it's like, would you want your child going back there? But I don't know. Yes, you'll receive a certificate, but that wasn't, I mean, maybe that was a boring case. I'm trying to think of some good cases that I've seen. I just can't think right now because, let's see. Okay, a time when I think that I actually saved somebody's life. Okay. Okay, so it was back when I was like my first year in the ER. So I had a patient come in. I was screening patients that day. And as I explained to you guys, screening is when you see patients, you're like one of the first people they see when they walk through the ER, and you ask them like short questions, and you kind of order blood. You start ordering some stuff, get some things started as they wait to actually be roomed and see it in a provider. So I was screening patients, and this lady came in and she told me she's having chest pain and she's short of breath. And so, so she's saying she's having chest pain and she's short of breath, and she just had a baby. And what would you guys think if a patient said that? Okay, if you guys don't know, so if a patient recently had any type of surgery, like a C-section, anything like that, and they're complaining of chest pain and shortness of breath, or even just had a baby, then you would think that yes. How do you guys know? You guys are so smart. This girl said PE. She's right. Gina, Ashley, yes. How do you guys know this? I didn't really know this. So yeah, so you were thinking blood clot. So I don't usually order this test called a D-dimer. I don't usually order it like in the waiting room. You wait to see a provider, but she was so like I think she was tachycardic, and I was just really concerned for her. And it was really busy that day. And I said, you know, okay, I'm just gonna order this test. So, no, I did order the test. I ordered the test, and I think she did end up getting seen by a provider. I think she ended up getting seen by a provider, or it's either I ordered the test and it was elevated, or she ended up getting seen by a provider. Yeah, this is what happened. I ordered the test, and she ended up leaving, and it was elevated. So she got the blood work done, but you know, like I said, they have to go back to the waiting room. So she went back to the waiting room. There was a long wait time. And so they said they came back, you know, super elevated or whatever. So I had to call her back. I'm like, ma'am, please come back. Please come back. Your test is elevated. And she's like, what? I'm like, please, I'm really concerned about you. Please come back to the ER. So she comes back to the ER. I guess she finally gets seen, and she had a blood clot. Yeah, she had a PE. So good thing I did it. So yeah, a PE is a pulmonary emboli. So I guess I'll discuss that these next 5 minutes. So a PE is a pulmonary emboli. What I was taught in PA school is that to be very, very afraid of this test. Well, not this test, to be very, very afraid of this condition, because it can kill you. And it's like a silent killer. So the person could be great one day, and then boom, they die. A lot of times when it was before people really knew what it was, patients would have surgery one day, and then a few days later they fall dead in the hospital. And so that's why they say it's like a silent killer. So my professor taught me to really, really always think about PE, just like you think about heart attack, just like you think about things that would kill a patient. So the way that it works is that it blocks, it's a blood clot. A lot of times it comes from your legs because you develop a DVT or a deep vein thrombosis. So it's in the deep veins, not a superficial vein, and it travels up to your lungs. And it blocks the arteries in your lungs. So it's blocking that ventilation. So there's no blood supply going into your blood supply or oxygenation going on. And then blood's not flowing back to your heart. So there's going to cause strain in your heart. It leads to a heart attack, you die. And it's just really, really bad. So you can't breathe, you're having chest pain, you're having shortness of breath. You get tachycardic because, that lack of oxygen and blood flow to your heart. And you can die. And there's risk factors for PE. So, and there's tests you can do for PE. like the D-dimer, but the D-dimer is a very non-specific test, which a lot of hospitals don't like to do, but it's like, but then you don't want to miss a PE. So then you ask questions to rule out PE. So they've developed these different risk stratifications to rule out PE without doing a D-dimer, because a D-dimer is a test that can be elevated whenever the body's breaking up a clot. So that's anything that can cause like, so if I was to cut myself and I was to put a Band-Aid on, a D-dimer can possibly be elevated because the body's forming a clot. Yeah, so it's just a very non-specific test. A lot of doctors, especially old school doctors, they do not like to order it. So a lot of people can get in trouble either, if you order it or if you don't order it. And so they develop these risk stratification questions to determine, along with, you can do that too, along with doing a D-dimer to say, oh, this patient definitely does not have a chance of having a PE or very low risk of having a PE. Don't ever in your notes say never or that you don't think that's what something is going on. It's best to use low suspicion, less likely, least. Don't ever use the words never or not, whatever, like completely exclusive words, because you don't really know. You can have a low chance of it, but it could still, even low, it could still be that the case. So, there's risk factors, as I said, for PE, like Verko's triad. You'll learn about that. It's intimal injury. Intimal injury means if you have an injury, which you can have injuries after surgery, you're injuring the tissues. Intimal injury, hypercoagulability, any hypercoagulable state where you're at risk for developing a blood clot, which is factor V Leiden deficiency. You'll learn about that. Any state that puts you at risk of developing clots, which is like genetic conditions or smoking is a hypercoagulable state. Pregnancy is a hypercoagulable state. So when a patient's pregnant, they're at risk for blood clots. Let's see, intimal injury, hypercoagulability, and venous stasis. Venous stasis means like you're just sitting there and the blood is pooling. You're not moving. You're not getting up and moving. In surgery, can cause all three of those, because intimal injury, hypercoagulability are 2 out of 3. In venous stasis, you're just laying there. You're not moving a lot. So truck drivers can be at risk of DVTs, people that have flown for a long period of time. So a patient also come in during a rotation. They flew from like Italy to the US, which is a long behind flight. So they can be at risk of having a blood clot. So all those are risk factors for a PE. The clot travels from your legs to your lungs, you can die. So it's really, when patients come in with those complaints, it's really important to ask questions like that to rule a PE out. Yes, birth control is a big one, right? Birth control is a big one because it's a hypercoagulable state with all that estrogen. Yes, stationary. It's not necessarily lifestyle. Lifestyle can put you at risk. If you just don't move around at all, like if you're bedbound, yeah. But that's why after surgery, they tell you to get, recommend that you get up and move around. And I also had a coworker just told me a story the other day of how a patient of hers had a saddle PE. A saddle PE is when it goes down the main branch and goes into both of the pulmonary branches. So both sides. It's not one side or the left side or right side, but both sides, which is super deadly. So the patient had a saddle PE. The patient went out of the country for surgery, for cosmetic surgery, and then she flew afterwards. So she didn't even give her body time to like really relax. She flew right afterwards. I don't even know if it was a week. I don't really know the story, but the full details. But she had surgery, which is one risk factor. Then she went to fly between countries, which is another risk factor. Any flying that is like, what is this, more than 6 hours can put you at risk. So so she did that. She came in complaining of chest pain, shortness of breath, and she had double PEs. So I'm glad your grandpa's stable. So you guys learned about PEs today. birth control, smoking. If you're on birth control and you're smoking, no. That's 2 risk factors. Yeah, 2,000 hours. Sorry. What was the meningitis thing? Okay, who wants to hear the meningitis story again? Do you guys, I mean, it's 8:05. I can either end the session, or if you want to hear the meningitis story, if I get enough people that say yes, then I'll. Oh yeah, online PA programs. I don't know. How would they, like, I recommend in person. I recommend in person as far as online versus in person. Okay, you guys want to hear the meningitis story? Okay, the meningitis. I actually shared this story in my first eShadowing session back in November. So I'll talk about the meningitis story. All right, so it was my very first. It was what I started in the ER February 14th, and the meningitis thing happened early March. So I was like in the ER for literally like a month, right? So I go see a patient. You remember that? Yes. Yes, I go see a patient, and he's this young guy. And it stuck with me, or it's sticking with me because it sticks with me because he was so young. He was very, very young, like early 20s. This young guy, I went to see him. He was just behaving strange. And I'm like, okay, like he was behaving strange. Like he was just like very agitated, irritated in the bed, like moving around. And I'm trying to talk to him, and he's like, just holding on to his head. Like you could tell that he has a bad headache. So he's holding on to his head. He's telling me, oh, his head hurts. And I'm like, is your neck stiff? He's like, yeah. And then all of a sudden he has a seizure. And then I asked him his name. I think before the seizure, I asked him his name and he was fine. And then after the seizure, I was trying to, no. Before the seizure, I asked him his name, and did he tell me? I think he was disoriented, but then he has a seizure. And I'm like, oh my gosh, he's having a seizure. And like I said, I'm super new in the ER, so I'm just kind of freaking out. And thankfully I see a doctor walking by, and I say, doctor, come help me. So then he has a seizure, but he wasn't really post-ictal. So we were able to kind of ask him questions and try to figure things out, but he wasn't really, responding. So it's not like he had a seizure, like he has seizures. We were trying to find out if he had seizures, but like I said, he wasn't really responding, but he didn't really seem to be post-ictal. But so we were just trying to find out, like, has he ever had a seizure before? What's going on? So we got in contact with his mom. And then his mom's telling us that he's been behaving strange recently. He doesn't have history of seizures. He's never had a seizure. And so he had a temperature. He's complaining of this bad headache, and then he had a seizure. So then the first question the doctor asked me is, what should we do on this patient? What do you think is going on with this patient? I tell him do a CT. Right off the bat, I'm thinking meningitis, okay? And let me tell you why. Because I really like the way that my school taught me. The way they taught me really prepared me for the ER, because I always think like worst first. I'm always thinking like, make sure it's not the worst thing possible, especially with him complaining of a bad headache and a possible fever. And so we did a CAT scan, of course, and it was negative, and he had another seizure. So we're like, okay, this guy, something's going on. So we're like, okay, we're gonna have to do a lumbar puncture on this guy. So the doctor ends up doing a lumbar puncture. And with the lumbar puncture, when you do a lumbar puncture, you have to measure, it's gonna measure the opening pressure. That's gonna, CSF. This guy's, the opening pressure, like the CSF will like go up, like it'll go skyrocket in the tube. So this guy's CSF like almost spilled out, and the doctor said he's never seen such a high opening pressure in his life. He's never seen anything like it in his life. He's like, this guy has to have a crazy meningitis. And he's like, this guy, he's gonna have it's gonna be something crazy. So I'm sitting there like, oh my gosh, this is so I mean, it's sad, but us nerds, we're like, oh, this is exciting. I'm ready to learn. So, and then while we wait on the test results and stuff, he's just declining. And he was in a lower acuity area of the hospital. So we had to move him to the main side of the hospital and monitoring him. And we had to, we were going to try to intubate him because he was having way too many seizures. But I think we held off on that. So then, his CSF comes back with the culture comes back with cryptococcus, and the doctor was like, he has to have HIV, he has to have AIDS because that's such a rare meningitis. And so it's very, very rare to get cryptococcus. Cryptococcus is in soil, but people that have healthy immune systems, they inhale it or whatever, they come in contact with it, they don't get sick because your body can fight it off. But somebody that has no or very, immunocompromised, they get in contact with it and it can make them sick. So this guy, his symptoms started literally a week before. He was seen at he was seen at the hospital the week prior, and they said it was sinusitis. So, and this is how deadly it is. He was seen in the hospital the week before. He died 8 days later. He died the next day, unfortunately. So he had cryptococcus, and then we ended up doing an HIV test, and it did turn out that he had HIV. So he didn't know he had it, because I asked him that. I think that was like, when did I ask him if he had? I don't remember at what point I asked him, but he said no when I asked him. So he didn't know that he had HIV. So, he didn't look super sickly or anything. So, and at that point, his family was at the bedside. So it was really weird. I didn't say it, but I'm not the one that broke the news to him. The doctor broke the news to the family, but it's like, it was really morbid and sad, like having to tell him that. And he didn't even understand at that point that that was the last of hhis worries, because he was not oriented enough to know that, oh, I have HIV and oh, I'm dying. We had to let his family know. And it's like, imagine, as, parents, you have a son, you have a child, and, to you, everything's going fine. They're healthy one day. And then the next day, or they get sick, and you're thinking, oh, he just has a cold, whatever. He's going to be fine. He's going to get better. And then all of a sudden, boom, you go to a hospital and you find out, oh, your child is not only dying, but has HIV and has had HIV for so long, to the point that, oh, now it's AIDS, and now he has this opportunistic infection. Because at that point, that's what the cryptococcus was. It was an opportunistic infection. So, so now he has this, and we couldn't even keep him at our hospital, but we had to transfer him to another hospital because our hospital didn't even have enough of the medication to treat him. That's how rare it is. So I think we were able to give him one dose, but he got transferred. I had to leave work. I didn't want to leave, y'all. I think I stayed pretty late at work that day. But we had to transfer him. And the reason I remember him is because, and I think he did end up being intubated like later in the night, like before he got transferred. So before I left work, I went to see him, and it was like when he was more alert. And he's like, was like kind of like this. And then he like kind of stared at me, and it's weird. I'll never forget this. I'll be 40 years old telling people this story. And yeah, he was like, looked at me, he was like, oh, you've been so nice to me. You've been so sweet. And then he kind of smiled at me, and then he kind of went back to sleep. And that's like my the last memory and thought I have of him. So unfortunately, when I got to work, like a few days later or the next day, whenever I worked, I heard that he passed at the hospital the next day. So yeah, very sad story, very, very sad story. So, it's just to have something so rare, be so young, and then, have your whole life ahead of you, not knowing that, this may happen. And that's the thing with working in the ER, you come into contact with all these different patients and people, and, you want to learn. If you're like me, you want to learn about people's walks of life. You're so interested in like, humans kind of, and you love like hearing people's stories or learning about people's stories or or not even if you don't hear it, you kind of envision how someone's life is. And you have that compassion, and it's just really sad, because I just keep thinking about, oh my gosh, what if his life could have been this? What if his life could have been that? How he had so much in store for him, and he for it to happen so young. So they didn't get to move him. He was able to be transferred to the next hospital, but yeah, that's my story. Yeah, I do cry at work. Okay, you guys want to hear one more story? Oh my gosh, maybe I should save this story for later. A time where I did cry. I think I said this story before as well. 5 minutes and then we're ending this session. A time where I did cry at work. I didn't even try to cry. I wasn't working. I was a PA student. The thing is, I didn't even try to cry. I was with a classmate and she started crying, and I was just kind of trying to comfort her. I really try not to cry at work. I try to hold it in because I don't want to come off as selfish, and it's about the patient. But this I'm not gonna say one story is sadder than the other. There's no such thing. I mean, people, that's a person's life. A person's life is a person's life, Another sad story I would say was as a student. So that's just going to teach you how to carry yourself as a student. I know it's all going to be new, seeing all these traumatic things, especially when you do your ER rotation, potentially seeing these traumatic things. But it was a peds ER. So one reason I do not want to do peds is because I can't take kids. I'm kids are a very soft spot to me. So if I was to see a child sick, dying, whatever, I can't hold. Adults I can do, but children, I'm just I would break down. That's I would cry for a kid. I would cry for a kid. Like I said, if somebody was to die really young, I can't do it. So so it was for the most part in the peds ER, a lot of it was kind of silly stuff, nothing serious, cough, colds. When you see them, they get better really quick. Kids are, their immune systems, when you reach that age, you'll get sick easily, but you'll bounce back. So it was nothing a lot of the times, but this day was different, and I'll never remember this day either. So it was a code. A 17 or 19-month-old baby. You guys, oh my gosh. So he was 17 months. And can you guys hear me? You guys can't hear me or no? Somebody said hello. Can you guys hear me, or let me know if you can hear me? Did it cut off? Can you guys hear me, or did it cut off? Okay, good. I'm sorry. So it was a 17-month-old with that coded. And I'll never forget the sight of this child. He was blue in the face. His belly was so distended because there was nothing but water in there. So they were together in the room and they were watching a movie. Mom and baby were watching a movie. Mom falls asleep. Baby, being a baby, gets up, awakes, walks around the house. I guess one of the doors was open. Walks to the bathroom. The door in the bathroom led to the pool area, the backyard. Baby gets through the door in the bathroom and drowns, falls in the pool and drowns. Mom wakes up, who knows how long later. Moms wake up frantically looking for baby, chasing, going crazy looking for baby. I don't know how long she was asleep for. By the time, she got there, baby was, down in the pool. Of course, police, everything was called, but it's just the sight of that poor baby. The ambulance rushed in. It was the saddest night. I mean, the saddest day ever in that ER. Everybody was sad. It was dead quiet throughout the whole ER. They brought the baby in, still like, you know, doing compressions. Like they did not stop, because you don't want to stop on a child. They did not stop doing compressions on this baby. They did compressions on him until I don't even know how long. They kept doing compressions and they finally had to call it. The cry of that mother will haunt somebody. Like you just had to like do your best to hold your composure. Like nurses were going into rooms crying, because you don't want to cry in front of the family or whatever. So people were going into rooms trying to find anywhere to cry. And then one of my classmates just kind of started crying in front of everybody, and somebody had to take us and push us to a room. But you just don't want to do it in front of the family. But it was just the saddest thing ever to witness a baby die, especially from a drowning. The saddest thing, like to see their lifeless body. It was terrible. And then to hear moms cry, it's like, oh my gosh, like the cry of a mother is just. So it's traumatic things like that you remember, and that's the downside of being a provider. But it just makes you appreciate life and makes you appreciate just people. And so it's really hard. Yeah, I can't do peas. Yeah, water. When I have kids, definitely. I mean, I encourage everybody, put your kids in a swimming class as soon as they can, they're able to, as young as they're able to. So yeah, this was in 2015. Very sad story. So yeah, I mean, ER has its ups and downs. Codes are definitely the worst things ever. So yeah, it is 8:20, guys. I hope you guys enjoyed this session. I got more. I actually have another code that happened. I can't tell you this one because it's 8:20, but it was another sad one. It actually happened in New York, but yeah, definitely important to hear the good and bad of any profession. The bad's always the dads. The dads you'll never forget dads. So yeah.